name is Amanda Lois. I'm one of the breast radiologists at York Hospital. So I'm a breast specialist. The topics I'm going to touch on today include breast awareness with some epidemiology, a lot of screening, and in the news yesterday, there was the update by the American Cancer Society with some new guidelines, so I'm going to touch on that as well. For the talk, what I decided to do was I put in what the recommendations were as of before yesterday, and then what they've changed to as of today. That way you can get some idea of how things are moving, in what direction. I have a couple other topics I'll discuss, and then I'm happy to take as many questions as you have afterwards. Just a little bit about myself first. I am from Gloucester, Massachusetts, the home of the perfect storm. I trained at University of New England up in Biddeford, Maine for medical school. I went to UMass for my internship. I did my fellowship for 5 years down in Philadelphia at Hahnemann Hospital, and then I was up at Beth Israel Deaconess for my breast fellowship. And now I've been here at York Hospital for 5 years. All right, so I'm going to just start with some epidemiology, just some SEER data about breast cancer. So about 1 in 8 women in the U.S. will be diagnosed with breast cancer at some point in their lifetime. So look in the room, there's going to be more than, there's probably 2 or 3 people that will potentially have breast cancer in the room alone. As far as the SEER data projected for 2015, the new cases of invasive breast cancer is over 231,000, which equates to approximately 125 women out of every 100,000 women, with an additional 60,000 cases of carcinoma in situ, which is the stage 0 cancer. The estimated deaths from breast cancer in 2015 is only about 40,000 plus. So breast cancer accounts for 14% of all new cancers diagnosed in the U.S. It's primarily clearly a female cancer, and only accounts for about 6.8% of all cancer deaths. And what I'll show in the talk is some of the reasons why we have such good survival is because A, we have good screening, B, women are taught to be aware of their breasts, and C, good treatment as well, advances in treatment. So just for those who are visual, which I am, basically the new cases per year versus the number of deaths, there's quite a nice gap in there. And the percent of survivorship, 89.4% of women diagnosed survive, do well 5 years plus out. So it's very encouraging. If we look at the percentage of new cases diagnosed per age group, and sometimes these can look a little different depending on how you look, but this is new cases per age group. It peaks between the ages of 55 and 64, and this is based on the current SEER data, which is the U.S. data. The median age at diagnosis is 61. And what I want to draw attention to is with the American Cancer Society new guidelines that just came out yesterday, what they say is for women at age 55 and above, every 2 years or every year, which is a change. It had been annually. Age 55 and above, that's when the majority of breast cancers are diagnosed, and somehow the conclusion was drawn that women can at this point go to every other year if they choose. Okay, again, breast cancer, if you're looking at new cases, it's at the top of the list. And then estimated deaths, though, is not as bad. And again, increased detection through screening mammography, the concept of self-awareness of your breast, and better treatment. This is basically just saying that again. I'm going to keep going. Survivorship, again, 89% of women are still alive at 5 years. And how many women are living with breast cancer in the U.S.? Almost 3 million women are living with breast cancer. These are our survivors. Okay, so I just wanted to discuss briefly some risk factors. Some things you can control and other things you can't control as far as helping to not develop breast cancer, and then we'll talk a little bit about prevention as well. One thing none of us can control is your gender, right? For the most part, I guess. Female gender, 100 times more common in women. 1 in 8 women versus 1 in 1,000 men. It certainly does occur in men as well, just not as common. And the leading theory would be that men have less estrogen and less progesterone, which is a driving factor in developing breast cancer. Aging, your risk of developing breast cancer increases as you get older. If you look at the population under age 45, 1 in 8 breast cancers occur in women under age 45. I'll draw you to the new ACS guidelines again. It says women between the ages of 40 to 44 who it was recommended up until yesterday have annual screening mammograms, that's now an option if you wanted them, and they recommend it beginning at age 45. But 1 in 8 women between the ages, or under 45 I should say, that's our breast cancer population as well. And typically, unfortunately, these are the women who have the most aggressive breast cancers, and that's where we get our most what's called life years lost. Okay. 2 and 3 invasive breast cancers are found in women at age 55 or older. Okay. To continue with risk factors, there is certainly a small component are genetic. 5 to 10% of breast cancers are genetic. I'm going to briefly discuss the entity of hereditary breast and ovarian cancer syndrome, which is the BRCA1, BRCA2 gene mutations, in a couple of slides. That's the mutation that we know about through Angelina Jolie. And certainly that's the most common cause of hereditary breast cancer. And in these patients, your risk of breast cancer increases up to 87% versus 12% in the general population. And they also have an increased risk of ovarian cancer. Family history of breast cancer. I do have a lot of patients who I see who say, I don't have a family history of breast cancer, so I don't really worry about it. Maybe they come in every 3 years or whatnot. And approximately 85% of women diagnosed with breast cancer do not have a family history of breast cancer, so it certainly wouldn't be a reason not to be screened. Okay. Dense breast tissue, this has been at the forefront as far as how we're educating patients about the breast tissue density. It was started by a grassroots group of women in Connecticut. A woman had dense breast tissue, her cancer wasn't seen, and she said, hey, had I known I had really dense tissue and it limited my mammogram, I would have gone for the additional test, the ultrasound. So she basically formed a group. They've been very, very, very successful at getting education out there to women who have dense breast tissue that the mammogram is less sensitive in these women, and you can have additional screening with ultrasound or MRI if you're high risk. Essentially, women who have, and I'll go into this a little bit later, who have dense tissue, your risk of breast cancer with no other factors increases by 1.2 to 2 times the risk of the average woman. Okay. I'm not going to harp on the benign breast conditions, but certainly if you have had a biopsy in the past, there are certain findings that just show that you're at increased risk of breast cancer in the future. In particular, if you have atypia, maybe someone in the room has had atypical results, that raises your risk 3.5 to 5 times in the future of developing cancer. And then LCIS, which is lobular carcinoma in situ, is a type of, I'll say a high-risk lesion rather than a cancer that develops in your lobules, and it makes you at risk 7 to 11-fold of developing cancer, not necessarily at the site where we biopsied, but anywhere within either breast. So those patients are certainly considered at high risk. I'll just do a quick anatomy review here of the breast. So this is the breast as seen in profile. This is your pectoralis muscle in your chest, and the way that your breast is made is this is your nipple here, then you have ducts that converge upon your nipple, and then you have lobules. The function of the lobule is to produce milk. It puts the milk into the ducts, which would then exit the nipple. This, depending on how much of this you have, that's how dense your breasts are or not. As you get older with age, your body knows it's not going to be making milk anymore, so some of those glands start to atrophy. They get replaced by fat, which looks black on a mammogram, which makes a mammogram easier to read. Okay, just other risk factors. Your menstrual cycle, believe it or not, the longer that you had an active menstrual cycle, that increases your risk. So if you were late to have your period, early to have menopause, then that's considered protective. And then also women who haven't had children, who never stopped their periods, are considered at higher risk. We do have patients who are survivors of Hodgkin's lymphoma. Certainly if you've had radiation to your chest as a child, which would be the standard treatment for lymphoma, I will see breast cancer in these patients in their 30s. There is increased screening guidelines for this particular subgroup as well. DES exposure is another risk. Hormone replacement therapy is also does increase your risk of developing breast cancer as well. And that's with the combined hormone replacement therapy, which is usually prescribed if you have a uterus still. If you don't have a uterus, then usually it's estrogen alone, and that does not show an increased risk. A risk model that we use at the breast center, the reason that we ask patients for their history is every patient that seems to have a somewhat significant family history will run their risk to see what their risk is for developing breast cancer. Any patient that we see for a screening mammogram will assess to see if they qualify for any other screening, and I will say that the American Cancer Society guidelines did not change in respect to the high-risk patients. High-risk patients, they also do recommend have breast MRI to supplement their mammograms. Typically, if you fall into the high-risk category, we'll do the breast MRI 6 months after your mammogram, because if you are high-risk, it's thought that you're at increased risk for developing a cancer. If we do your mammogram and your MRI at the same time and then wait a year and something develops, it'll be bigger than if we stagger the examinations by 6 months. So if we stagger them by 6 months, if something does develop, there's a better chance it'll be smaller, and that'll give you, the patient, the best chance for a cure. So just to show you, this is the most sophisticated model that's out there. It's much better than the Gale model, which is used by most other facilities. It gives patients age, their menstrual history, whether they've had a biopsy. Of significant ancestry would be if you're Ashkenazi Jewish, and then it gives a very detailed family history. Most models only use first-degree relatives. This goes out to cousins, which includes third-degree relatives. Okay, so breast cancer prevention. So some of the risk factors you clearly can't control, but there are some that you can. So, and some of this is the common sense. It's what your PCPs are probably telling you anyway as far as healthy lifestyle, but it certainly has been shown in studies. Things such as having active lifestyle, increased physical activity, which really means a low BMI, which just means you're a lean person, decreases your risk of developing breast cancer. Alcohol intake. So fat produces estrogen in your body, which increases your risk, believe it or not. So body weight, physical activity, and diet have all been linked to breast cancer. And then other things as far as prevention is if you do have a strong family history and you do meet the current guidelines, you could certainly consider genetic testing for the hereditary breast and ovarian cancer syndrome. It's ideal to do that before you were diagnosed with breast cancer. That way you could go ahead and you have options if you wanted to either increase your surveillance or have prophylactic surgery that would then greatly decrease your risk of developing certain cancers. Kind of went through this already. So a diet rich in, so this is like the common sense, vegetables, fruit, poultry, fish, and low fat is what's been shown in studies to decrease your risk. For women who are at increased risk, again, a strong family history, known genetic mutation, or some of those biopsy, that DCIS, LCIS, and again, some things that you can do genetic testing. There is chemo prevention such as tamoxifen that you could electively take, and then preventive surgery such as getting your breasts removed or your ovaries removed. I'm going to briefly just tell you about hereditary breast and ovarian cancer syndrome, and I didn't add any slides because I just wanted to talk about this. And again, 5 to 10% of breast cancers are secondary to this mutation. It occurs in about 1 in 4,000 of the general U.S. population. If you're Ashkenazi Jewish, it's 1 in 40 women carry this mutation. It's not just important in women, it's important in men as well. As you can see by the name of it, it's breast and ovarian cancer syndrome. So if you inherited this gene mutation, this is something that we'd be able to look, if we looked at your pedigree, we'd be able to tell that perhaps from your mom's side or equally from your father's side, you could have inherited a mutation in what's called the BRCA1 or BRCA2, and it's just BRCA, which just stands for breast cancer 1 or breast cancer 2. I'll give you a quick genetics lesson, and you guys will all feel like experts. Basically, in all the cells in our body, there's 46 chromosomes, and it's 23 pairs. You got 23 from your mom, 23 from your dad. Just say theoretically your dad carried the gene mutation on BRCA1 or BRCA2 gene. He has So BRCA1 is on chromosome 17. He has 2 copies. He either has the good copy or a bad copy. He has a good and a bad copy. There's a 50-50 chance he's either going to give his child the good copy or the bad copy, because he gives 23, his wife gave 23 to form the next child, okay, if that makes sense. So it's a 50-50 chance, 50% chance that if it's in the family, that the parent can give it to the child. Does that make sense? Okay. So if you inherit this gene mutation, your breast cancer risk goes up to 87%, your ovarian cancer risk goes up to 44%. In the general population, less than 1% of women develop ovarian cancer. To me, I'm a breast specialist, but I will say when I do have my patients who test positive for BRCA, it's not the breast cancer that I'm worried about for them, it's the ovarian cancer. I know that we have excellent screening with mammograms and personal exam and breast MRI for these patients, that if they do develop something, we're still going to find it small, chances are. With ovarian cancer, your ovaries are very, very small structures centered in your pelvis. They'd have to get awfully big, the tumor, in order to detect it. And usually when it is detected, it's a stage 4. So those are the patients that I'm more concerned about the ovarian cancer than the breast cancer in these patients. Typically the standard of care for patients who are diagnosed with breast and ovarian cancer syndrome for women is they can either continue with mammograms and MRIs on a 6-month basis, do breast exams once a month, and see their clinician every 6 months for breast exams. That's for the breast. Alternatively, they can get what's called prophylactic mastectomies. You're thinking 87% chance of breast cancer. A lot of women might say, I just want my breasts removed before I develop cancer. By doing that, you decrease your risk of breast cancer by over 90%. About 50% of women decide to keep their breasts and have screening, and about 50% of these women who test decide to have the mastectomy. It's a personal choice. We just give them the information so they can make a choice. As far as the ovarian cancer, essentially the standard of care with ovarian cancer prevention is if you've had your children and you're done, you get your ovaries and your fallopian tubes removed. And that's the standard. By doing that, you decrease your risk of developing ovarian cancer. Believe it or not, it's not 100%, but by 96%, because you can still develop it, believe it or not, in the inner lining of your abdomen. But by doing that alone, it decreases your risk of breast cancer by 68%, believe it or not, just getting your ovaries removed. In men, because you can certainly, this can be in men as well, breast cancer rate goes up to 1 in 8. Aggressive prostate cancer as well, and then it can be associated with pancreatic cancer in men and women, as well as melanoma. Because that's what I have to say about that. All right, so finding breast cancer early. And then this is where I decided to keep my slides the way they are, and I'll address the American Cancer Society guidelines changes after. Other than lifestyle changes, the most important action a woman can take is to follow the American Cancer Society's guidelines for early detection. Early detection will not prevent breast cancer, but it can find it smaller, best chance for treatment and cure. So it's the difference between what I do as early detection versus what patients can do with their lifestyle changes is prevention. Okay, so the concept of self-awareness, I thought it would be worth a while to take a minute just to review how to do a breast exam. Essentially, the best way to do it is you want to lay down on your back with your arm over your head, and what that does is it flattens your breast out and makes it as even as possible. You use your middle 3 fingers, and as it shows, you just go up and down, and you want to do it 3 times. Light pressure, medium pressure, heavy pressure. And what you're looking for is a hard lump or any change, any type of lump. It can be as small as pea-sized. And then also you'd sit up and just see if there's any skin divots or anything like that. The other thing as far as breast exam is if you have spontaneous, which means not pressed on, clear or bloody nipple discharge, that would be something to tell your doctor about as well. Okay. So it's basically women in their 20s and 30s can do it's either breast awareness, clinical breast exam every 3 years. Again, just how to perform it. And so I kept this in, let's see, women age 40, which is the recommendations until yesterday, should have a mammogram every year and should continue to do so as long as they're in good health, which I will address also when to stop having your mammogram. And then current evidence supports mammogram is even, this is funny because this was on their website as of yesterday, current evidence supporting mammograms is even stronger than in the past. In particular, recent evidence has confirmed that mammograms offer substantial benefit for women in their 40s. So despite that was what was put in there yesterday, today it's changed to 45. There's close to a 40% reduction in deaths from breast cancer because of screening mammography. And then women who receive annual mammograms starting at age 40 can reduce your risk of dying of breast cancer by 71%. This is significant. Screening works. Okay. So when to stop? Mammograms should be continued regardless of your age, as long as you don't have a serious chronic health problem. The general guidelines is to stop if your life expectancy is less than 5 to 7 years. And the reason for this is when we screen and find the cancer, if it's very small, your survival isn't going to be that immediate. It's going to actually be 5 to 10 years out that it would have progressed and led to a death. So that's why they say if you're not going to act on it because your life expectancy isn't that long, then it's fine to stop screening. It's a hard conversation for a primary care doctor to have with their patient, but that's just the way that it would make sense to stop. Or the other way to look at it also is if you had an abnormal mammogram, if you wouldn't do anything, then maybe you don't need to have mammograms anymore, which is fine. We have women that are in their 80s that are healthy, definitely continue to screen them. If there's a woman who's in their 50s and is chronically ill, it may not be the best thing that woman needs at the time, and it's a personal choice that they should make with their primary care doctor. Okay, so again, I'll just read what the American Cancer Society guideline is now for us. As of before 11:15 a.m. yesterday, it was 40 and older, and now what they're saying is women from 45 to 54 with an average risk of breast cancer should get annual mammograms. Women should have the option to begin annual screening at 40. And women 55 years and up, and again, I showed you the statistic that the number of new cases are from 54 to 64, can switch to every other year, but should have the option to stick with annual screening if they choose. So to me, it's just more wishy-washy. Technically, it's still saying you can start at 40 and go as long, but then it's also saying you can go from 45 to 55 every year and then go every other year. And I will say, I was aware just because of the meetings that I go to, the annual meetings for Society of Breast Imaging and the ACR, I knew 2 years ago that there was going to be a drastic change in the American Cancer Society guidelines. I didn't know when they were going to come out. But I will say at that time, it was thought that they were going to more reflect what's called the USPS the USPS task force recommendations, which actually were just to get mammograms from age 50 to 75 every other year, and that's it. That hit with, so that's really where they were trying to go with this, and ultimately so much data was thrown at the American Cancer Society that they did at least back off of that, and it's more wishy-washy. If you've taken an Economics 101 class, there's no question why the recommendations are changing, but that's something we can discuss later. Okay. So now I'm just going to go into some of the imaging, because that's what I am. I'm an imaging specialist. So I can tell you what we offer here at York Hospital. We do have the new 3D tomosynthesis, so the mammograms, which formerly were 2-dimensional and now 3-dimensional. I'll show you some examples of those. And the 3D tomosynthesis finds about 40% more cancers. It's great. It looks through the dense breast tissue. It's really, really good. We're finding a lot of small cancers in dense tissue. We offer the Philips breast ultrasound as well as the Philips Ingenia 1.5 breast MRI, which we started last November, which is excellent. And then we also offer all biopsy capabilities, stereotactic, which means a mammographic guided biopsy, which is typically for calcifications, ultrasound guided biopsies, which are the best for the patients. They're very quick. And then MRI guided biopsies for something you can't see any other way but by MRI. So I want to quickly talk about 2D, which is what was here until recently. And to be honest, we're the only hospital in Maine that offers 3D mammography. We're it. And then there are some others on the seacoast that do as well. So the rest of the state is still doing the 2D digital. And I have to say the digital was so actually, believe it or not, my training was in film screen. I know I don't look that old, but that was in film screen, and then I was trained in digital, and now I'm trained in 3D. So at least I've been able to see the history of how this has evolved. And the 2D digital was a great improvement over the film screen. So what it is it's a two-dimensional picture of your breast, and the limitations of it is if you have dense breast tissue, the reason we compress you isn't because we want to hurt you, it's because we're trying to get the dense tissue to compress out so we can see through your tissue. So the more compression you tolerate, the easier it is for us to read your mammogram. And so with 2D, sometimes there's overlap, and sometimes we have to take additional views, roll the tissue around, see if we can get it to not look, to make sure we can look through it well. So with 2D, there was increased number, well, relatively now to 3D, of what I'd call callbacks. At our facility, we do the workup the same day. If we see something that looks nodular, we just send the tech back in to do the additional views, which is great because it decreases the anxiety of having to get notified, wonder what the heck's really going on, come back in and get the views. We just do it all at the same time. That way we can get you an answer, which is nice. It definitely decreases the anxiety from that. So 3D mammography has been shown in numerous studies that it increases the detection of invasive breast cancers and reducing recall rates. It was approved in February of 2011, so these are really the key stats. With the 3D, there's a 41% increase in the detection of invasive breast cancer, 29% increase of all cancers, and a 15% decrease in the women who are recalled for additional imaging, which is nice. That's just less anxiety there. So what is tomosynthesis? We look at the breast in 3 dimensions. What it is now, and I'll show you a schematic of it, is the unit, which many of you have probably been in. Instead of being stationary, it now has a mobile component. So it takes a 15-degree arc over your breast. It takes much lower dose, 15 images. It does a computer back algorithm, much like a CAT scan does, except this is much lower dose than a CAT scan. And it allows me to go through your breast in 1 millimeter intervals, just like an MRI does, and look through the dense tissue. It's like reading through the pages of a book. So this is the unit here. And again, what it's showing is on 2D, if you had a cancer in here with a lot of dense tissue around it, there's a chance that you wouldn't be able to see it due to tissue superimposition. And what I'm able to do, like the pages of a book, is I'm able to scroll through slice by slice and find that small spiculated mass in there. It's a really great modality. Better sensitivity, hard to see a mass. I can see it very well on a 1 millimeter slice here. Another example here, this looks like something funny, but when you scroll through, all it is tissue lined up in 1 dimension that it superimposes, and this didn't need to get I didn't need to recall the person because it clearly wasn't a mass. So as I said, it arcs over. It arcs over the patient and takes 15 slices that are low dose, and this is well within the dose limitations set by the FDA. So mammography is one of 2 imaging modalities that is strictly regulated by the FDA as far as dose to the breast. A couple of cases here. Can you guys see this okay? This is the patient's regular 2D mammogram. As I scroll through, you can see that there's clear architectural distortion here. On the 2D, just looks like normal tissue, clear architectural distortion. This was a patient who had a breast cancer. Probably would have been overlooked on a 2D. This one here, you can see that there is some asymmetry out there. Again, more tissue throughout the upper outer quadrant of her right breast. And again, when you scroll through, you're able to see that there is a well-circumscribed mass. From here, we'd go into ultrasound, better characterize it, see if it's a cyst, see if it's solid. If it's a cyst, we can disregard it. If it's solid, it needs to be biopsied. This is a really good case here. Again, that's her 2D. If I scroll through, you can see this very, very tiny spiculated mass. Again, very, very tiny stellate spiculated mass. That's a tiny little 6 millimeter cancer that has a great survival rate. Catch these small. Again, key points, 41% increase detection, 29% increase in all, and 15% decrease. I'm going to now talk about whole breast ultrasound. The concept of whole breast ultrasound really came about when I was discussing the woman from Connecticut who wanted what other options are out there if I have dense breast tissue and I'm not a high-risk patient. Whole breast screening ultrasound can be performed. It's 0 radiation, just like MRI is. It's no radiation. It's ultrasound transducer over your breast. We look through the dense tissue. We let you know if there's something suspicious or not. Because we do tell you what your breast density is and when you come in. So this is someone who's completely fatty, it's black, it's going to be easy to see a cancer. Cancer are white on a mammogram. This is someone who's scattered. They have some scattered tissue, and again, what is this? It's the fibrous tissue, it's your lobules, it's your ducts. This is someone who's what we call heterogeneously dense, and this is someone who's extremely dense. The extremes are only about 10% each of the population. The majority of women fall into here, 40%, 40%. If you take what's the average, it's a B+. The average woman is a B+ here. And it's the people who are a C or a D that the state of Maine has asked us to inform women that they have dense breast tissue. It can limit the sensitivity of your mammogram, and if you wanted additional screening with ultrasound, it's available. We do provide screening breast ultrasound at our facility. Not a lot of facilities do offer it. But it is out there, and I'll show you data that shows we certainly do find more cancers with it. And again, as I had said, basically as far as your breast density, about half of women qualify for additional screening with ultrasound because they have dense breast tissue and half don't. The relative risk of women here is about 1.2 the average and about 2 times the average for developing a breast cancer just based on density. Again, I already reviewed what it is. It's the fibrous tissue. It's very hard for an X-ray beam to penetrate the dense tissue, which is why it looks white. If it's just fat, the X-ray beam goes right through it. It looks black. It makes it easy. Some factors that affect your density, most of them you can't control. I'll just let you briefly look at that. Okay, so advantages of screening with breast ultrasound is it looks through the dense tissue, so it's not going to miss a cancer because you're dense. It looks right through it. There's no radiation, there's no IV contrast, which you do get with MRI. There's no compression like a mammogram, and it's relatively inexpensive. Here's a case of a patient who has really dense breast tissue. Yes, there's a cancer hiding in there. When you have 2D, and I'll show the stats afterwards, but when you had 2D mammography, breast cancer detection rate, if you add ultrasound, so it's usually 8 in 1,000 women that are diagnosed with breast cancer. If you add ultrasound to these patients, you find another 3 to 4 cancers per 1,000. That's significant. 8, 3 to 4 on top of that, that's significant. So this is what cancer looks like on ultrasound. The skin is up here, the chest wall is down here, and this is an irregular mass. It's small. What we do on ultrasound is I make something really small look really big so I can take a look at what its features look like. This is a small little cancer. It's something that wouldn't have been seen. Hopefully it would have been seen the next year on our mammogram, but the tissue is dense. Another patient with dense tissue. Right breast, far medial breast. There's a cancer here. Again, you can kind of see what it looks like, an irregular gray to black mass. And there were 2. She had 2 cancers in her breast, believe it or not, that weren't seen on the mammogram. Were they missed? They weren't missed. You just couldn't see them. Okay, the clips, one of them is up in this area. The other cancer was down in this tissue. They're both in her inner breast. Doesn't look any different than any other part of her breast. Another case, again, just another example that I have. This was a stage 2 cancer because this patient had lymph nodes. I was asked to just include a staging slide here. Basically what it shows is breast cancer is staged from stage 0, which is the in situ cancer, very early to stage 4, which means distant mets, and clearly the earlier you find it, the better this 5-year survivorship is. Okay. So basically what ACRIN is the American College of Radiology Imaging Network. When you prevalence screen, the first ultrasound that you do on patients, you're going to see as many as 11.8 cancers per 1,000 from 8, so 8 to 12. So it's a pretty good increase in cancer detection. And the key really is that the cancers that were found on this large study of ultrasound is they were small. 89% were node negative. Median size was only 1 centimeter. So by adding ultrasound, you can still find small cancers. And then how does Tomo weigh in? Because as I said, Tomo is finding more cancers. So if you put Tomo now instead of the 2D mammography, we're still finding an additional 2 cancers per 1,000 out of the general population if you add the ultrasound. Screening for high risk. Basically, the American Cancer Society still agrees that adding MRI is helpful. If you combine both mammography with MRI, it's a 93% sensitivity, 93% chance that we're going to find your cancer. That is very, very good. Okay, I'm just going to show one case of an MRI, that way you guys can see what MRI looks like. This was a 45-year-old female we had who was a BRCA1 mutation carrier, family history, mother and sister diagnosed with premenopausal breast cancer, maternal cousin at 50, her grandmother at 45, mammogram was normal. And then we identified her as a high risk. Clearly she was, because she was BRCA positive and had an MRI. Very, very small mass. This is the right breast, the left breast just behind her nipple, small enhancing mass. We did an MRI guided biopsy because we couldn't see it on the mammogram, couldn't see it on the ultrasound, see it on MRI only, and it was a small invasive cancer. All right, breast density legislation. Since 2009, a strong and vocal patient-driven grassroots movement has systematically pursued state legislation requiring radiologists to provide written breast density information to patients as part of your mammogram results. So what these women want is they want other women to be educated, to be told, if you have dense tissue, we should at least let you know that. And if you wanted additional screening, such as ultrasound if you're normal risk, or MRI because you're high risk, it's available. It's a personal choice. I can't tell you what to do. I can just tell you the information that's available. Okay, there is right now Dianne Feinstein out of Democrat out of California is the newest representative who has proposed the Breast Density and Mammography Reporting Act of 2015, and basically what that says is that the radiologists have to inform patients that they have dense breast tissue. It may limit your mammogram, and there is additional imaging available. We're supposed to tell the patients in writing. And then it's different. So we have federal and then we have the state, right? So at the state level, it's all over the place, which is fine, but I will show you a little map about that. Let me just continue. So this I updated over the weekend on October 17th, and this is the dense state efforts. And what the women who started in 2009, they actually targeted 10 states, which covered 50% of the U.S. population of females. So they were pretty smart about it, to let women know that you have dense tissue. Okay, and what this shows, Maine is in blue, and newly New Hampshire and Vermont are now in blue, and what that says is that we're working on a bill to pass, but there is a resolve in the state of Maine, a resolve for us to tell women that they have dense breast tissue, to have it in writing, and to keep it in the report. Some of these states, Connecticut being one, New Jersey just joined, Indiana, Illinois also have mandated insurance coverage for it, which is nice. I think I counted it up. 33 states are informing women. Okay, so as I said, Teresia Hayes is the representative out of Maine, and it's a resolve of an act requiring communication of breast density to patients. This is a good website that we give to patients if they want it, and I can give it to you again after. So now I'll talk about breast cancer controversy. I actually had this, I had this in before the guidelines came out yesterday, but I had a lot more I could have included, but I decided I didn't know how long the talk was going to be. But, so I'll just talk a little bit historically, because screening mammography has been basically challenged ever since it really was incepted back in the 1980s. So I'll just show you some data. Mammography screening is one of the major medical advances in the last 50 years. It has undergone greater scrutiny and more challenges than virtually any other medical intervention. Opposition has persisted for over 40 years, despite continually mounting evidence of its efficacy. Randomized controlled trials. This is the gold standard of how you perform a trial. Randomized controlled trials have unequivocally shown a statistically significant mortality reduction for screening beginning at the age of 40. Okay. When screening is introduced into the general population, the death rate declines. Despite this, efforts continue to try to limit access and discourage women from participating in screening. So this is the relative rate of breast cancer death in 8 randomized trials. So this would mean that there's nothing significant. If the study was along this line, that meant we introduced screening and it didn't help. The studies, which you can see, almost all the studies are to the left of this line, except for 2. They all show that when you introduce screening mammogram, deaths declined. Okay, there's 2 studies. These are the Canadian national studies from 1980 to 1985. 2 studies that were, when you look at them, were not randomized control studies. That actually showed if you introduced screening, more women died, which is just doesn't make sense. And if you look at that study, which I took out the criticism of, but I'll briefly tell you, is it wasn't a randomized controlled study up in Canada. What had happened was, it was actually, the goal of that study was to show if clinical breast exam helped. So each patient got a clinical breast exam and then was put into one of 2 groups, either screening with mammography or not. So that's not blind, and it wasn't randomized. And it wasn't a good study. If I showed you the technique that was used, so this is 1980, right? They were using 1970s mammograms, and before that there was no grids, there was no standardization, it was basically just white. So I can imagine that they probably weren't reading very well back then. But I will say what is unfortunate is it's this study, it's the Canadian National Study 1 and 2, it's the same study that they just carried out more and more years out. Guess what study the New York Times chooses once a year to relate to tell us that mammography doesn't work? It's this study, it's the Canadian study, it's none of the other large, better designed studies. And what you do is if you put a doubt in a woman's mind who doesn't want a mammogram anyway, it just makes them not get it, unfortunately. So if we look at SEER data, which is the Surveillance Epidemiology and End Results of the United States, so this is the SEER data. Before screening began, there was a pretty steady death rate of breast cancer. For breast cancers, believe it or not, before SEER, we followed this back with what's called the Connecticut Tumor Registry much further back, and it's basically a straight line up here. Then you introduce screening in the 80s, and then as I said, there's about a 10-year lag time, and then what happened? We introduced mammography, the death rate increased by, depending on the patient population, 30 to 50%. Okay. The United States Preventive Service Task Force, which came out several years ago, which it was clear their guidelines, which I'd alluded to, was a mammogram from 50 to 75 every other year. It means there's 13 mammograms in your lifetime. It's very easy to calculate costs from that. How did they bias conclusions? They took women who were 30 to 49, and there is a large jump between the age group from 35 to 39 to 40 to 44. There is actually a large jump in breast cancer rate, which is why we start at 40. But they grouped women 30 to 49 and then 50 plus. And it makes it look like there's this large, huge gap. Why wouldn't you start at 50? But if you look at it, the reality is it's a slow, gradual incline. It's a perfect incline. You know, each year that you're alive, your risk increases. So there's no big jump from 49 to 50. So as far as trying to not support the USPSTF guidelines, there are no data. There's no studies that started at age 50 that show that has a survival benefit. And the other thing that the USPS task force was saying was this increases anxiety. Women can't take the anxiety of being recalled. They can't take the anxiety of a biopsy. If you talk to women who are diagnosed with cancer, they certainly are thankful that we diagnosed them. And there's no jump in, this is the recall rate. If you look at women from their 40s to 50s, the recall rate, it's a straight line. So you can't use the argument that because women are younger that they have dense tissue, that there's this huge increase in recall and patient anxiety at this level. It's simply not the facts. Biopsies recommended. You can see this is a straight line. It's not that in your 40s so many more biopsies are being recommended because we can't see what we're doing. That's not the case at all. It just isn't. But it's falsely used to try to discourage women in their 40s from getting their mammograms. This is the data. Okay, so I already went through what the ACS updated guidelines were, so I'm not going to read that again. Of course, I'll say, is economics an issue? It may be. Now, I just want to give a counterpoint. This is the society I belong to, the Society of Breast Imaging. Why start screening at age 40? They were prepared. We knew that this was going to come out at some point, so I just wanted to give just 12 points that are very, very valid as to why to start at age 40. And that it's also valid, as I showed earlier in the SEER data at the beginning, that it probably isn't the wisest to start every other year at age 55 because that's when the number of new cases are at its peak. It just doesn't make sense. Data doesn't support the recommendation. All right, so I'm just going to quickly just go through these bullet points just as a counter to the ACS, and then I'll be just about done, okay? So annual screening mammography starting at age 40 results in the greatest mortality reduction, the most lives saved, and the most life years gained. Women in their 40s, they have little kids, they have jobs. Life years is important. This is why the American College of Radiology and SBI, which is Society of Breast Imaging, recommends regular mammography in women 40 and older, 40 to 49-year-olds, not 45 to 49-year-olds. Breast cancer incidence, as I said, increases substantially around age 40. The incidence of breast cancer from 40 to 44 is twice that from 35 to 39. That's why we start at 40. Okay. 1 in 6 breast cancers occur in women aged 40 to 49. 40% of life years saved by mammography, 40% of life is in women in their 40s. The years of life lost to breast cancer are highest for women. That would make sense just because they're the youngest. The largest and longest running breast cancer screening trials in history have reconfirmed that regular mammography screening cuts breast cancer deaths by roughly a third in all women ages 40 and over. That's very compelling. There is another, so a recent pan-Canadian mammography study involved over 2.7 million women screened in Canada showed an average mortality reduction of 40%, which was the same for women in their 40s as for older age groups. The USPS task force, after they came out with their recommendations 5+ years ago, have since acknowledged an increase in total number of lives saved and life years gained in women who start mammography in their 40s, even though they continue to say 50. Let's see, analysis by this group published in American and AJR shows the current mammography screening rates. Annual screening starting at 40 saves approximately 6,500 more women's lives each year. Annual screening results in more lives saved for breast cancer than biannual screening, and the USPF now shows that annual screening beginning at 40 provides the most lives saved, but they don't change the recommendation. And then mammography screening cuts the risk of dying from breast cancer nearly in half. So it goes on and on. So it's clear that we should be starting at age 40 and going annually. And then the ACS also just said instead of 5 to 7 years, life expectancy 10 years, which I think is fair. So the conclusion: get your annual mammogram annually, beginning at 40 or 45 if you want to use the most current ACS guidelines, until your life expectancy is less than 10 years or you wouldn't act on the diagnosis. So I'm going to quickly tell you what we offer at York Hospital, and then I'll open to questions. So we're the only hospital on the Seacoast to offer same-day results. If you come in for your mammogram, if there's an abnormality, we're going to work it up right then. You don't get a letter 2 weeks later to have to come back. We work it up, we'll do the ultrasound. If we see something suspicious on your ultrasound, you can even have a biopsy performed then. Myself and my partner, Dr. Rebecca Haltman, are both breast fellowship trained radiologists. We took additional training beyond the usual residency to get specialized in a breast fellowship. We're trained to do all the, read mammograms, ultrasound, MRI, and perform all biopsies. That's what we do all day. You don't have a neuroradiologist. You don't have the guy who doesn't want to be doing it, reading it. I've been there. I know what people think of mammography. Most of them don't want to read it. I love reading it. I love women's health. Okay. We're the only hospital in Maine, as I said, with 3D tomosynthesis, and we are a breast imaging center of excellence. We're not the only hospital with that in the area, but we are. And what that means is we have to uphold the strictest of regulations throughout all imaging modalities, as far as dose, surveillance, quality data, etc. We give same-day results. Again, myself and Dr. Haltman are on-site reading the examinations live. The equipment I had already mentioned before, the 3D with the Philips and the Ingenia. This is our team. This is some of us at least, some technologists. This is Gail DeRoche, our nurse navigator, who came with me today. And this is Dr. Haltman, who recently joined our group. She was out at UMass, so she was out in the Worcester area, which is great. There is a lot of survivorship for our patients, and it's due to endless hours from very dedicated people, whether it be women in the community, men in the community, basketball teams, different groups as far as giving financial help, etc., for our breast cancer patients who are trying to get through the diagnosis. Patients who maybe have to stop working, patients who might need gas cards, grocery cards, financial assistance, women who might need a prosthetic, might need wigs, hair pieces. The list goes on and on. We have physical therapy help. I know Susan can answer this better than me. We offer Reiki, we offer massage, we have Nordic walking classes, we have cooking classes. You name it, I feel like we have it. There's been a tremendous amount of support through that. And we've been very, very, very grateful for that. Here's some helpful internet resources. And the patients are very helpful for that as well. And that's my talk, so thank you for listening.